So monitoring alveolar recruitment by CT scanning. Then if we look at all the techniques we have discussed here, I think that I must say that CT scanning, of course, is the gold standard. This is first of all because it's my topic, so this is the gold standard technique, and also because I will show you what we are really measuring with CT scanning. But we have a strong limitation that is not available yet at the bedside. So to support this statement, what I would like to do in the next 15 minutes is, first of all, to give you a brief rationale and explanation of the methodology behind CT scanning, and then give you some insights that we have obtained with the application of CT scanning in ARDS patients. And at the very end, I will discuss very briefly any possible clinical application of this technique. Well, the first introduction of CT scanning in ARDS dated back in 1986. I was, I think, a little child. I was not there. This was the first article published. And at that time, there were two different groups that more or less in the same months decided to take a patient, an ARDS patient, to CT scanning. And there was a big surprise because what was usually thought to be an homogeneous disease was actually not homogeneous. With CT scanning, it was clear that we have quite normal lung region, and the disease of the lung is localized more in the dependent part of the lung. But how can we measure lung recruitment by CT scanning? So first of all, we know that a CT scan image is made by voxels, which are little squared. And a voxel, if we consider lung parenchyma as a mix of air and tissue, and with the term tissue, we include epithelial and endothelial cells, extravascular fluid, so edema, blood, fibrin, and all cellular debris. And we assume that the lung tissue density is equal to 1 gram per ml. We end up in the region of lung in terms of Hounsfield units, which measure the density of voxel to this range between 0 Hounsfield units, which corresponds to all tissue, so no air at all, and minus 1,000 Hounsfield units, which corresponds just to air. So it follows automatically that if we have a voxel with minus 750 Hounsfield units, this means that that voxel or that lung region has 75% of air and 25% of tissue. So just calculating the lung area and multiplying the surface area for these percentages, we are able to quantify the amount of air and the amount of tissue. Now, this is another representation of showing the CT, the frequency distribution of all the CT numbers of each single voxel for a CT scan image. And based upon a CT frequency distribution, we can separate the lung in different regions characterized by different degrees of aeration: hyperinflated tissue, normally aerated tissue, poorly aerated tissue, and non-aerated lung tissue. This is a frequency distribution of CT scan from a healthy subject, and all the lung, most of the lung, is in the normally aerated tissue. We have about 60–70% of the lung tissue as air, but this is what happened with ARDS. Most of the lung is shifted towards the non-aerated lung tissue. So from this simple, I would say, measurements, we are able to quantify different lung tissue weight characterized by different degrees of aeration. Now, how do we perform CT scanning? A couple of practical suggestions. First of all, in static condition, and this is quite simple because if we perform a CT scanning without any inspiratory or expiratory pause, basically, and we perform CT scanning during respiration, in the time of CT scanning, 5 to 10 minutes, we have different breaths. And with a single breath, we have air coming into the lung, and this changing the lung density, and therefore we end up to have an average estimate of the degree of aeration of that lung parenchyma. So we need to take a CT scanning in a static condition. But we have another problem. When we see white stuff on the image, CT scanning, this can be related to two different phenomena. We may have, in a single voxel, white voxel, many different alveoli all collapsed, or we may have some alveoli filled with cellular debris, edema, and so on. So how can we discriminate these two conditions? Also because the reopening of these units is actually defined as lung recruitment, while usually we are not able to open lung consolidation. It's quite simple because we need to change the characteristics of the system. This means that we need to take two CT scanning at two different airway pressures, based upon the assumption that if we applied a higher airway pressure, we are able at least to open part of the collapsed lung regions. And therefore, we are used to perform two different CT scanning at a very low pressure, 5 centimeters of water PEEP, and at high inspiratory airway pressure. And we define lung recruitment as the difference and the reduction of non-inflated or non-aerated lung tissue. So what did we learn with the application of CT scanning? Well, I think this is one of the most recent studies, and it's really important. It has already quoted by previous speakers because it compared different methodologies, different techniques to compute lung recruitment. And in this study by the group of Cumello and Gattinoni, 22 patients with ARDS have been studied with two different CT scanning at 5 and 15 centimeters of water of PEEP. And the calculation of lung recruitment by CT scanning was compared to the calculation of lung recruitment by different methods, PV curve, lung volumes, respiratory mechanics, and so on. And of course, there was no agreement between lung recruitment as estimated by respiratory mechanics. Here is just the PV curve method, and lung recruitment as calculated by the reduction of non-aerated lung tissue, but this is quite easy. These are two different entities, as we have already discussed before, because one thing is to define recruitment as the reopening of collapsed unit, and another thing is to define lung recruitment as the sum of a reopening of collapsed lung unit and an increased inflation of already open lung units. Usually with the respiratory mechanics, CIT, and all the other techniques we have discussed before, we are measuring this type of lung recruitment, while the only possibility of measuring the real lung recruitment in terms of reopening of collapsed lung unit is CT scanning. When we increase PEEP from 5 to 15, as you can see here, we have a reduction of non-aerated lung tissue. And we have a shift towards a better aeration of the lung. But the increase in gas is related to the reopening of lung units, of collapsed lung units, but also to a higher degree of inflation of the already open lung units. So, and what we have learned in the past, this is a quite old study, 2006, 11 years ago. Time passed. And in which we applied for the first time to at that time, a relatively large cohort of ARDS patients, 68 patients, whole lung CT scanning in order to estimate the maximal lung recruitability in ARDS. And we observed that we have a huge variability of the maximal lung recruitability. We have patients in which going from 5 to 45 centimeters of water airway pressure, we are not able to open the non-aerated lung regions, the white matter, the white stuff at the CT scanning, while we have patients in which if we apply the same high degree of airway pressure, we are able to reduce the non-aerated lung tissue. And of course, the maximal lung recruitability appeared to be strictly related to the lung recruitment derived by the increase of PEEP from 5 to 15. If we have patients with high lung recruitability, if we apply higher level of PEEP, we are able to keep open about 50% of the lung, while there's no sense, no rationale to apply a higher level of PEEP in patients with low lung recruitability. And this is a more recent study published a couple of years ago. Probably this article has not gotten an easy title, very long title, I guess, and in which we decided to investigate the possible relationship between ARDS severity according to the novel ARDS Berlin definition based upon gas exchange, PO2 FiO2 ratio, and ARDS severity based upon CT scanning findings. And the assumption was that, of course, according to the ARDS Berlin definition, ARDS severity is based upon gas exchange at the clinical PEEP. But we know that PEEP may influence lung recruitment, the opening of the lung, and therefore gas exchange. So basically, our hypothesis was that the better association between ARDS severity according to the Berlin definition and ARDS severity according to CT scanning was obtained by reclassifying patients according to ARDS severity, taking gas exchange at a similar low level of PEEP. So this is what we observed when we classified patients according to ARDS severity at clinical PEEP. As you can see, of course, patients with severe ARDS showed higher lung recruitability as compared to all the other groups, but we are not able to observe any difference between mild ARDS and moderate ARDS. But look at these two CT scanning. These are two patients classified as having mild ARDS at clinical PEEP, and these were the two CT scanning taken from the two patients at 5 centimeters of water PEEP. These patients, of course, was better than these patients. And when we reclassified that patient according to gas exchange at 5 centimeters of water PEEP, it remained in a mild category, while we classified these patients according to gas exchange taken at 5 centimeters of water PEEP, it went to the severe category of ARDS. And this, of course, was lung recruitability. These patients had a higher lung recruitability as compared to the other patients. And this is why when we reclassified ARDS severity according to gas exchange at 5 centimeters of water PEEP, we observed a more linear association between maximal lung recruitability, CT scan ARDS severity, and ARDS severity according to the Berlin definition. So do we have any clinical applicability of CT scanning at the bedside? I would say no, because so far we need hands to draw the lung boundaries. We need a software, a specific software to arrive to the quantitative analysis of CT scanning, and we need time. So this is a time-consuming technique not available at the moment at the bedside. And we need also to transfer the patient to CT scan facility. This was, I think, a nice attempt to compare a visual assessment of lung recruitment by a visual analysis of CT scanning and lung recruitment according to the quantitative analysis of CT scanning. In this work by Cumello, Gattinoni et al., they compared an estimate according to a visual scale based upon 18 segments of the lung and the lung recruitment, two different CT scanning at 5 and 45 centimeters of water airway pressure. And of course, there was a good agreement with a high specificity and high sensitivity of the visual approach as opposed to the gold standard technique, the quantitative analysis of CT scanning. But I think that still this methodology is quite complicated because it requires the analysis of different 18 segments, and it's still time-consuming. So what do we do at the bedside? Well, I think that we applied what we called in Italian il metodo occhiometrico, the eye metric method. So we just look at the image, two different images at two different airway pressure, and we try to estimate if that patient has high lung recruitability or low lung recruitability. So every time we have a patient with ARDS, if it's possible and feasible according to the clinical situation of that patient, we perform lung CT scanning at two different airway pressures, at 5 and 45 centimeters of water airway pressure, or if we have an already higher level of PEEP at the clinical PEEP and 45 centimeters of water to estimate the lung recruitability. And we try to use this information to set PEEP. If we have higher lung recruitability, we normally apply higher level of PEEP between 15 and 20. And if we have low lung recruitability, we normally apply a PEEP level between 5 and 10. Thank you very much for your attention.